Can a 40-year-old cholesterol medication, Simvastatin, treat multiple sclerosis? Today we'll take a walk on the path less traveled and look at how this drug might help people with MS that results in several scientific studies, including the famous MS-STAT study, a randomized controlled trial in secondary progressive MS where Simvastatin reduced both brain atrophy and disability. We'll look at the side effects and future directions, and I'll give my personal opinion. And keep in mind that Simvastatin is just zocor, an old, dirt-cheap cholesterol medication. It's long been generic. There's no drug company promoting it. There would simply be no economic incentive. It was originally approved in 1991. It works on the enzyme HMG-CoA reductase, which is an enzyme involved in cholesterol synthesis. It blocks that enzyme, so you synthesize less cholesterol in your liver. It's used to treat high cholesterol and has specific evidence for reducing the risk of heart attack and stroke in individuals who are at higher risk for those conditions. The typical dose used for cholesterol is 5 to 80 milligrams, but the dose used in MS is 80 milligrams, a very high dose, and of course there could be a greater risk of having side effects such as muscle aches or, in rare cases, serious liver injury. But how exactly would Simvastatin benefit people with MS? Well, no one knows for sure, but here are a few possible mechanisms of action. One is that some studies show some link between cholesterol levels and prognosis of MS, people with lower cholesterol having a better prognosis, so maybe just lowering cholesterol itself is good for people with MS. But also statins, including Simvastatin, are thought to have some effects other than lowering cholesterol. For instance, they're used even in people with an acute heart attack. Obviously, coronary artery disease develops over many years, but they may have some benefit in the short term due to anti-inflammatory effects. Some basic science studies have found reduced activation of T cells and also a shift in T cells from a T helper cell type 1 phenotype, Th1 phenotype, to Th2. And this is similar to the mechanism of action of beta interferons used to treat multiple sclerosis, such as beta-serin, Avonex, and Xtavia. They also may have an action similar to Tysabri, blocking leukocyte migration, or white blood cell migration, through the blood-brain barrier into the central nervous system. And they also inhibit nitric oxide synthase, which normally would lead to free radical production, so it may indirectly reduce free radical damage from activated microglia, which are a type of white blood cell in the central nervous system known to contribute to inflammation in MS. But enough speculation, let's see what actually happens when you give people with MS Simvastatin. And this story starts in 2004, a small pilot study, and it has some big name authors, Timothy Vollmer and John Corboy, who are still active MS researchers to this day. Now, this is a small, open-label, uncontrolled pilot study. Open label meaning people knew they were getting Simvastatin and there was no control group, so it's not a great methodology. There were only 30 participants with relapsing remitting MS, and this is just a before-after study looking at people before they got the drug, comparing them to after they got the drug, but they did find the average number of gadolinium-enhancing or active lesions decreased by 44% after the treatment after a 6-month period. The p-value looks impressive, but this is not a great methodology because people often enter studies when their disease is active and there's a natural regression to the mean phenomenon. But this pilot study inspired future research, including the first randomized controlled trial published in 2010. Now, this looked at people who were taking the drug beta interferon 1A intramuscular once weekly, also known as Avonex. This is a low-efficacy disease-modifying therapy. So everyone in the study, both getting placebo and Simvastatin, were taking disease-modifying therapy. Also note that this was a study of Simvastatin 40 milligrams, which is half the dose of the 80 milligram dose that was used in the famous MS-STAT study I'm going to show you later. This was a randomized controlled trial. People did not know whether they were getting the treatment or the placebo, and they looked at people with relapsing remitting MS with an expanded disability status score, EDSS, less than 5, meaning they were walking independently without a cane. And the results were somewhat impressive, but definitely not definitive. People getting Simvastatin compared to placebo had a lower EDSS, or measured disability, at the end of the study at 1.01. This is very low disability disability, almost nothing. People in the placebo group had an EDSS of 1.73, and this is a pretty big difference over a short-term study, but everyone was doing well, and it was not statistically significant simply because by coincidence, people randomized to simvastatin had lower baseline EDSS. The p-value was only 0.07, not quite to the 0.05 threshold. In terms of active lesions, they were very similar, 0.66 with simvastatin, only slightly lower than 0.74 with placebo, not statistically significant. And in terms of new T2 lesions, they were coincidentally exactly the same, 3.39 versus 3.39. So this study favors simvastatin, but is definitely not clear, and there was no statistically significant difference in any of the measured outcomes. And this study was followed shortly after by the SimCombin study published in 2011, which was a larger study with 307 participants. Sim stands for simvastatin, Combin, combination therapy, because these people were also gating beta interferon 1A, in other words, Avonex. So again, these are people who are taking disease-modifying therapy. It was a randomized controlled trial of simvastatin, this time 80 milligrams, the full dose, versus placebo in people with relapsing remitting MS, and this one was an utter failure. In fact, people getting simvastatin seemed to do somewhat worse, if anything. They looked at the relapse rate, the annualized relapse rate, or relapses per person per year, which is 0.19 with simvastatin versus 0.14, even less with placebo. Now keep in mind, these are low rates of relapses. 0.19, or roughly 0.2, is one relapse per 5 years, which is a low rate of relapses in relapsing MS, typical of a treated individual with relapsing MS. In terms of lesions, there were actually more new T2 lesions with people taking simvastatin, 2.96 versus 2.52 with the placebo group. And in terms of no evidence of new disease activity, NEDA, it was only 6% in people taking simvastatin versus more than double, 13% in people taking placebo, p-value of 0.05. None of these things were statistically significant, but if anything, they favored the placebo group. And the authors say, we found no beneficial effect of simvastatin as an add-on therapy to interferon beta 1A, in other words, Avonex. So really, overall, this is the largest study in relapsing MS. It was just not beneficial, and you have to accept this result and perhaps put it away in the file cabinet. I'll also share with you, beyond the scope of this video, there are various studies with the drug atorvastatin, Lipitor, a stronger statin in cholesterol-lowering effect, and it also had relatively poor results in relapsing MS. But what about in progressive MS? And right on cue, we have the famous MS STAT study. Researchers decided to move from relapsing MS to progressive MS, and this is a study against placebo in secondary progressive MS. It's a randomized, double-blind, controlled trial, simvastatin 80 milligrams versus placebo. There were 140 participants. It's a 2-year study, ages between 18 and 65, and you had to have an expanded disability status score or level of disability between 4 and 6.5. This is between moderate disability and requiring a walker to walk, EDSS 6.5. And these people were not taking disease-modifying therapy. And this may also be a key difference from those earlier studies where people were taking Avonex. Perhaps simvastatin does some things that disease-modifying therapies do, such as the anti-inflammatory effects. This was done in England, 3 centers in the United Kingdom, and it was 1-to-1 randomization against simvastatin 80 milligrams, the high dose, versus placebo, and their primary outcome was brain atrophy, shrinkage of the brain, which can be accelerated in multiple sclerosis compared to normal aging and has been associated with worsening disability. And before we get to the results, I want to show you who was in the study. These are the baseline characteristics of people randomized to placebo, 70 people on the left, and people randomized to simvastatin. You can see that almost everyone in the study was white, so we may have limited applicability to people of other ethnicities ethnicities, and most people were not having relapses, only 17% of the people getting placebo in the 12 months prior to the study versus 10% in people getting simvastatin. You can see the average age was around 51, and the average multiple sclerosis disease duration was 21 years, and the mean duration of progressive MS was around 7 years, and the median EDSS, or level of disability, was 6.0, which means the typical person in this study needed a cane to walk 100 meters, which is relatively higher disability compared to other progressive MS studies, such as the oratorio study used to study Ocrevus in primary progressive MS. So we'll move to the results, and I'll start with the primary outcome, which was the rate of brain atrophy or brain shrinkage. If you look at this chart, you can see simvastatin in light blue versus placebo in dark blue. This first section on the left shows the first year of the study, comparing the MRI after 12 months to the initial MRI prior to randomization. This second part is the second year of the study, comparing the final MRI to the MRI done after 12 months. And this last section, which we should focus on, is the full study, comparing the final MRI to the MRI done prior to randomization. In other words, prior to getting simvastatin or placebo. And you can see anything above this dashed line represents brain atrophy or brain shrinkage. A small number of people even getting placebo had more brain at the end of the study. Of course, placebo isn't growing your brain. It's just that brain volume can be affected by other things such as hydration status, so it can vary a little bit. And there is some measurement error with these quantitative MRI software comparing brain volume from one MRI to the next. But on the average, there's definitely less brain atrophy in people who are randomized to simvastatin. To quantify that, the brain atrophy rate in people taking placebo was 0.584% per year, which is elevated. A normal aging person loses about 0.2% of brain volume a year, even without any neurological disease. With simvastatin, it was 0.288% per year, close to normal aging. This is a 43% reduction, and it was highly statistically significant with a p-value of 0.003. Now, interestingly, the researchers did a lot of statistical analysis after the fact. This is a separate publication, but a post hoc analysis looked at the MS STAT study and saw, was there a correlation between lowering of cholesterol and reduction of brain atrophy? I can't claim to understand the complicated math that they use, but they say no, there was no association whatsoever. How much your cholesterol went down had nothing to do with the rate of brain atrophy. So in this publication, they believe that the effect on brain atrophy has absolutely nothing to do with the cholesterol lowering effect. It must be something else. Now, keep in mind that reducing brain atrophy sounds impressive, but it's not a very clinically meaningful outcome. In fact, there's studies on other drugs showing that even subtle effects on hydration and electrolytes can affect this volume of cells and can affect brain atrophy in a sort of trivial way. Even people who run ultra marathons can temporarily have a lower brain atrophy. That doesn't necessarily mean we're preserving neurons and axon. We want to look at more clinically meaningful results, such as disability and quality of life. And luckily for us, the researchers looked at that too. These are their outcomes for EDSS, again, a measure of disability in MS, comparing placebo to the left and simvastatin on the right. The mean EDSS at the end of the study was 6.35 with placebo versus 5.93 with simvastatin, p-value of 0.01, statistically significant. And this is a very clinically significant difference. Keep in mind that EDSS 6 means you need a cane to walk. EDSS 6.5 means you need a walker to walk. That's a huge difference. Here on the left, you can see the individual results color-coded based on changes in EDSS. So blue means no change in EDSS, the same before and after the study. Light red means a slight worsening by 0.5. The slightly darker red meaning worsening by 1. And you can see a small number of people did significantly worsen by an EDSS of 1.5 or 2.5. But you can can see a small number of people randomized to simvastatin actually got better, mostly slightly better, but some of them significantly better. And overall, you can see there's a clear trend towards people getting simvastatin to have a better chance, even though most people stay the same or get slightly worse, which is what I would expect in people with progressive MS over only a 2-year period. And they looked at some other outcomes as well, such as the MS Impact Scale, a measure of quality of life related to multiple sclerosis, and you can see placebo on the left, simvastatin on the right. There wasn't a statistically significant difference, p-value greater than 0.1, but there was a trend towards people getting simvastatin to do a little bit better, and you can see there's a huge individual variation, but at least on the average, people with simvastatin did not have a worsening of their quality of life. It stayed about the same, where people getting placebo did slightly worse. Again, no statistically significant difference, but a slight average difference. And they looked at the MS Functional Composite, which I believe to be a superior measure of disability than the EDSS. It has things such as the timed 25-foot walk, how fast you can walk, the PACE-SAT, a measure of cognitive function, the 9-hole peg test, a measure of upper extremity function, and the mean change was minus 1.21. In other words, they got a little bit worse with placebo compared to minus 0.78 with simvastatin. Not a statistically significant difference, but a trend favoring simvastatin. You can see most people stay about the same, but there are a slightly greater number of people getting worse with placebo. Now, if you look at relapses and new MRI lesions, there was really no difference. The average number of new or enlarging lesions per year per person was 2.19 with placebo compared to 1.5 with simvastatin, a slight non-statistically significant difference. In terms of relapses, there were 0.16 relapses per person per year with placebo, slightly more, 0.2 with simvastatin. Really no differences here. The researchers tried really hard to pin down how simvastatin might be working, but they simply couldn't. They looked at various immunological markers, interleukin 10, gamma interferon, interleukin 4, but there really were no major differences between simvastatin and placebo, at least not in anything immunologically that they could measure. I should also mention the potential downsides of taking simvastatin. It's a very safe drug, no significant risk of weakening the immune system, but it can cause unpleasant side effects, especially muscle aches or rarely myositis and even muscle weakness, though it's unlikely to be significant. Some people do have to stop taking it due to side effects. It can cause elevated liver function tests, and in very rare cases, again, very rare, significant liver injury. There are also some notable drug-drug interactions. These are some drugs that simvastatin is known to interact with, including some common blood pressure medications like amlodipine or Norvasc. You could still potentially take it with amlodipine, though it's recommended to take a lower dose, no more than 20 milligrams. Same thing with diltiazem, another popular blood pressure or heart medication. There's also potential interaction with grapefruit and grapefruit juice, though usually with large amount of consumption. And if you're not convinced by the MS-STAT study, there's another study, the MS-STAT2 trial ongoing, which is a very similar Phase 3 trial, but it's bigger with the planned 964 participants with secondary progressive MS. Again, simvastatin 80 milligrams versus placebo, this time over 36 months or 3 years, ages 25 to 65. Again, EDSS 4 to 6.5, and the primary outcome is something better than brain atrophy, which is time to confirmed disability progression, and the planned completion date is August 2024, and you'll better believe you'll see an update here once it's released. But my personal opinion is that even without this second study, it's very reasonable to try simvastatin as a treatment for progressive MS. Sure, even if it's effective, the benefit is likely to be modest, but the side effect profile is just so favorable. So many people take these drugs anyway for high cholesterol, and if you develop muscle aches, you can always stop the medication. It's just so unlikely to cause serious harm. And keep in mind that other drugs used in progressive MS, such as Ocrevus and Mayzent, the benefit was relatively modest in clinical trials with a much, much greater risk. And this MS-STAT study had people who were somewhat older with less disease activity, so they were probably somewhat more difficult to treat. That being said, I'm prepared to eat my words. I wouldn't be entirely surprised if the MS Stat 2 study was unsuccessful. Again, the difference in the MS Stat study was relatively modest and only in some, not all outcomes. But I'd be interested to know, have you tried Simvastatin for MS? Do you think it was effective? Did you have any side effects? And do you have any suggestions for future videos?